Here's our quick roadmap for today. First, we'll cover the roundworm, Ascaris lumbricoides, followed by its investigations and treatment. Then we move into Asiatic cholangiohepatitis. Finally, we'll wrap up with mycetoma, looking at both its pathogenesis and spread and its diagnosis and management. Let's get right into it.
Section 1, roundworm, specifically Ascaris lumbricoides.
The step-by-step systemic migration pathway of this parasite is, well, it's pretty mind-blowing. Infecting a staggering 25% of the global population, this organism begins its journey via the fecal-oral route. Fertilized embryos can actually survive in contaminated soil in hot, humid climates. Once ingested, the larvae hatch in the jejunum, penetrate the mucosa, and catch a ride through the portal system and lymphatics straight into systemic circulation. They eventually reach the lungs, hang out and mature in the alveoli for about 2 weeks, and then, get this, they are coughed up and swallowed right back down. Back in the small intestine, they grow into adult worms that can be up to 45 centimeters long. And if that wasn't enough, during ectopic migration, these worms can wander off into the stomach, the common bile duct, or even the pancreatic duct. Now, while that intestinal phase causes abdominal pain and malnutrition, that pulmonary phase we just talked about, that triggers a very specific self-limiting condition known as Loeffler syndrome. This is precipitated directly by those larvae physically migrating right through the lung tissue. Clinically, it's characterized by a dry cough, chest pain, dyspnea, and fever. But here's where things get really serious. A massive worm burden can rapidly escalate into life-threatening surgical emergencies. Imagine an incarcerated bolus, basically a dense, tangled ball of adult worms, blocking the terminal ileum. This happens primarily in pediatric patients and causes an acute intestinal obstruction. If that dense worm bolus creates enough pressure, it can literally cause ischemic pressure necrosis, leading to a rare but absolutely deadly bowel perforation. Furthermore, remember that ectopic migration? If they wander into the common bile duct, it causes ascending cholangitis and obstructive jaundice, while infiltration right into the pancreatic duct triggers acute pancreatitis.
Moving into Section 2, roundworm investigations and treatment. So how do we track this parasite down? We utilize a rapid-fire sequence of imaging and lab modalities. Starting with hematology, you're going to see marked peripheral blood eosinophilia. Under microscopy, you might find stool ova or even sputum larvae and Charcot-Leyden crystals. When we move to imaging, plain radiography can reveal dilated small bowel loops containing these really distinct internal tubular structures. CT scans will actually identify the parasites as clear curvilinear structures. And for live, mobile worms wandering into the biliary or pancreatic ducts, ultrasonography and MRCP are highly effective, giving us incredibly sharp visualization. Finally, a chest X-ray will highlight those fluffy pulmonary exudates, which are the classic hallmark of Loeffler's syndrome.
The absolutely crucial point here is our strict escalation of care. We typically start with medical and conservative therapy, like IV fluids, nasogastric suction, and hypertonic saline enemas to try and disentangle that worm bolus. We do use anthelmintic drugs, but with a massive caution. Aggressive medical therapy can induce rapid worm death. That creates a dense, rigid bolus of dead worms that actually causes an acute intestinal obstruction. Talk about a backfire. So if conservative management fails, we escalate to surgery. Step 2 is a laparotomy. If the bowel is still viable, surgeons will literally try to manually milk the worm bolus through the ileocecal valve. If milking fails, step 3 is an enterotomy to extract the worms directly. And finally, resection is absolutely mandated if we encounter any strictures, gangrenous segments, or perforations.
All right, Section 3, Asiatic cholangiohepatitis.
For this condition, we're tracing the vector life cycle of the liver fluke, specifically the Tramatode Clonorchis sinensis. The parasite starts by developing inside its primary host, snails. Free-swimming cercaria then emerge and penetrate the flesh of freshwater fish and crabs. When humans ingest this raw or undercooked seafood, the infection takes hold. And honestly, the most staggering part about this entire process is that the worm matures and can survive right inside the human intrahepatic biliary radicles for decades. Decades! Over those decades, the fluke causes profound structural damage. The biliary changes include profound epithelial hyperplasia, periductal fibrosis, and uniform dilatation. Crucially, and this is a huge takeaway regarding oncogenesis, the resulting biliary epithelial dysplasia can progress directly into cholangiocarcinoma, which is a devastating liver cancer. We also see calculi formation, where dead worms or eggs form a structural nidus, basically a seed for stones. This is worsened by the production of mucin-rich bile.
Ultimately, all of this drives chronic obstruction, leading to ascending cholangitis and severe liver abscesses.
Because this condition relapses so frequently, diagnosis and surgical intervention are pretty complex. On ultrasonography, we're looking for uniform dilation of the small peripheral intrahepatic ducts with echogenic walls due to fibrosis. While early stages can sometimes be cured medically with prazoquantel and albendazole, established disease demands surgery. We're talking a cholecystectomy combined with common bile duct exploration. Intraoperatively, extensive and repeated ductal washouts are mandatory. We literally have to clear out stones and what surgeons call parasitic mud. Yeah, it's exactly what it sounds like. Furthermore, surgeons often create a biliary drainage pathway, like a roux on Y-axis loop anchored right to the abdominal wall. This provides interventional radiologists with simple future access to manage any recurrent stones.
Let's move into Section 4, mycetoma, pathogenesis and spread.
Mycetoma is a chronic, granulomatous, and highly progressive disease. The absolute diagnostic hallmark, the pathognomonic triad you need to look out for, features a painless subcutaneous mass, multiple sinuses, and a seropurulent discharge that actually contains distinct colored grains. It's a non-contagious condition, and it's typically inoculated via minor, often completely unnoticed trauma. Something as simple as a thorn prick when walking barefoot on soil where the organism resides can start this whole process.
There is a really direct structural difference between the two main classifications of this disease. Actinomycetoma is actually a bacterial infection. It's characterized by early, rapid, and highly extensive tissue invasion, often with lymphatic spread to regional nodes. On the flip side, eumycetoma is a true fungal infection. Here, tissue invasion is much more gradual and delayed. Even visually, if you look on an ultrasound, actinomycetoma produces less distinct echoes, whereas the fungal grains of eumycetoma produce very sharp, hyperreflective echoes.
As the lesion expands, it presents some truly unique clinical challenges, mainly due to its deceptive extent. Small surface signs on the skin can completely hide massive, complex networks of deep connecting tracts beneath the surface. Because of this, surgical intervention under local anesthesia is strictly contraindicated. You just don't know how deep it goes. The foot is affected about 70% of the time, leading to what's known as Madura foot. These painless swellings evolve into suppurating nodules, discharging those colored grains we mentioned, which can be black, yellow, white, or red depending on the organism. Yet, despite this visual destruction, the disease is strange in that it remarkably spares tendons and nerves until the very, very late stages. That explains the lack of early neurological deficits.
And finally, Section 5, mycetoma, diagnosis and management.
Getting an accurate diagnosis here is really a multimodal effort. Plain radiography can show bone scalloping and a sunray appearance that actually mimics osteosarcoma. But MRI is absolutely the modality of choice. It reveals the pathognomic dot in circle sign, which represents granulomas interspersed within a fibrous matrix. For cellular evaluation, fine needle aspiration cytology, or FNAC, helps differentiate between the bacterial and fungal forms. But listen to this. For a proper culture, a deep surgical biopsy under general or regional anesthesia is mandatory. Those superficial discharging grains, they are highly contaminated by the environment and are practically useless for growing a viable culture. This next part perfectly illustrates the cellular evolution of the disease across 3 specific histopathological tissue reactions. Think of it as a failing microscopic battle. In type 1, we see a dense layer of neutrophils literally attaching to and trying to fragment the grain surface. In type 2, the neutrophils disappear, replaced by macrophages and multinucleated giant cells that engulf the pigmented grain cement. Finally, by type 3, it transitions into a well-organized epithelioid granuloma containing Langhans-type giant cells. It is a stunning, albeit tragic, representation of the immune system's failing battle against the infection.
When it comes to medical therapy, the choice is tied directly to the organism. Actinomycetoma, being bacterial, is treated with cyclic combination antibiotics, specifically amikacin paired with cotrimoxazole as a first-line choice. Eumycetoma, however, requires long-term antifungals like ketoconazole or itraconazole. But here's the kicker. These antifungals are rarely curative on their own. Instead, their main job is to form a thick, fibrous capsule around the lesions. This localizes the disease, making it nicely packaged and amenable to surgical excision.
Which brings us to the operating table. Operative methods range from wide local excisions to debulking surgeries, and sadly, major amputations.
Because of that microscopic tracking along the fascial planes we talked about, surgical margins must be significantly wider than what the surface clinical borders suggest. In about 10 to 25% of advanced refractory cases complicated by sepsis, amputation becomes a necessary life-saving measure. And even with surgery and extended antimicrobial coverage, the disease still carries a daunting 25 to 50% post-operative recurrence rate. This is often driven by incomplete excision, mistakenly using local anesthesia, or simple drug noncompliance. So, we've seen how roundworms can literally obstruct the bowel, how liver flukes can silently initiate oncogenesis over decades, and how mycetoma deceptively destroys bone and tissue beneath the surface. Which leaves us with a vital question regarding the future of tropical medicine. With these parasites acting so deceptively, how can we improve endemic public health screening? Could routine hepatobiliary ultrasounds for migrants from endemic regions be the answer? We need to figure out how to intercept these elusive infections long before the surgeon's scalpel becomes our only option. Thank you so much for joining me on this explainer. Keep questioning and keep learning.